Great. Welcome back to House Healthcare. We are continuing our conversation on insurance claims processing. We do, just for those in the room, we do have 3 members who are home sick and joining us remotely. So thank you. Feel free to be on screen, off screen, and I will look for a raised hand or just jump in if you all have questions. Sometimes I forget you're there. So we will welcome Blue Cross Blue Shield to the table. So Dr. Tom Weigel is joining us. He's the Chief Medical Officer for Blue Cross Blue Shield. So we'll hear his testimony. And do you want us to hold questions or ask questions throughout or kind of see how things go?
Holding questions would be preferred.
Okay, we can do that. So
not a good memorizer. So.
That's fine. So if people want to jot down their questions as we go, that'd be great. So if you can introduce yourself for the record and then go ahead and start.
Sure. Thank you, Chair Houghton and the committee for having me today. Introducing myself, I'm Tom Weigel. I'm a board certified child psychiatrist. As a physician, I'm the Chief Medical Officer at Blue Cross Blue Shield of Vermont, where I've worked for over 2 years. Prior to that, I was the medical director at the Vermont Department of Mental Health. Originally, I'm from Wisconsin, where I attended undergrad and medical school. I moved to Boston for residency training at Mass General and Children's Hospital and spent over a decade working as a psychiatrist at McLean Hospital, which is a psychiatric hospital affiliated with Mass General. Today, I understand we're talking about claims edits. Briefly, I'd like to take a step back and first talk about CPT codes. It's an acronym for Current Procedural Terminology. CPT codes offer doctors and healthcare professionals a uniform language for coding medical services to streamline reporting, increase accuracy, and facilitate payment. We understand the challenges faced by provider offices. Medical coding can be compared to learning a new language, requiring significant training for coders to master. Last December, we collaborated with the Vermont Medical Society to conduct a training session focused on modifiers 25 and 59. The recorded webinar is accessible as a resource on the Blue Cross Vermont provider website. Additionally, our provider relations team is ready to assist and support practices as needed. Health insurance plans have a financial obligation to our members to review provider claims for accuracy, correct billing for the care provided, and identify cases of fraud, waste, and abuse. Both members and employers place trust in their health plans to make sure their health care bills are correct. Claims edits are a widely used method to review claims, ensuring accuracy and consistency in coding. To illustrate, think of receiving a detailed bill at a restaurant that lists all charges such as service fees and taxes, resulting in the total amount owed. This transparency is crucial in healthcare for patients. It's much like it is for customers in a store or a restaurant. Like checking your household bills, claims edits scrutinize and adjust claims to prevent overpayment or incorrect reimbursement for services. At Blue Cross Vermont, we rely on coding standards established by external bodies like the American Medical Association, the Centers for Medicare and Medicaid Services, or CMS, and specialty medical organizations like an ophthalmology organization. Blue Cross Vermont does not adopt edits that are unique to our health plan. Our goal is to ensure that claims use accurate codes that properly represent the services provided. We always expect comprehensive medical documentation in the chart to support each claim, akin to verifying items in your shopping cart against the store bill. The purposes of our claims edits are to ensure consistency in payment across all providers, to guarantee appropriate charges for our members, maintain consistent coding among providers, and level the playing field for our members and providers with other health insurance plans. Moreover, claims edits help to identify mistakes, serious coding errors, and inconsistency. All payers, including CMS for Medicare and Medicaid, utilize claims edits or conduct claims audits. Claims edits undergo periodic review and updates. In January of 2023, Blue Cross Vermont implemented several changes to these edits. These alterations were made following State Rule 903, which involves inviting the DFR to review the proposed changes and providing a 90-day advance notice to all providers. Each practice is responsible for adhering to national coding standards set forth by CMS, the AMA, and their own specialty organizations. I understand there's specific questions about modifiers 25 and 59. Prior to 2023, adjustments for inappropriate use of modifier 25 and 29 were made during post-payment provider audits. As of January 2023, we began reviewing modifiers 25 and 59 to submitted claims prepayment, similar to you pay your check when you get the bill. This means that our policy is not changed for these codes, but our approach to enforcement is more immediate. Modifiers 25 and 59 allow providers to bill for additional services when a patient presents with an unrelated second health issue requiring substantial additional work, such as requesting labs, referring to specialists, or additional treatment unrelated to the care they're receiving in the same visit. Addressing a separate significant health issue can increase the workload for a provider and rightly increases the cost of the appointment. I'd like to give an example of billing both 25 and 59 modifiers. Regarding modifier 25, and I have seen a chiropractor, so this is a reasonable example. Suppose I visited a chiropractor for neck pain. For the first visit, the chiropractor billed an initial evaluation. Subsequent visits for my neck pain were billed as a procedure visit for neck adjustments. They were cracking it. If during the fourth visit, I arrived to the chiropractor with new back pain unrelated to the neck issue, the chiropractor would assess this neck pain. In addition to billing for adjusting my neck, they'd also use modifier 25 to bill separately for evaluating and managing my new back pain. However, some chiropractors incorrectly use modifier 25 for every single visit, even for simple adjustments of existing conditions. An example of a 59 modifier would be if a surgeon performs an ACL repair, anterior cruciate ligament in the knee, on a patient's knee. The code for the surgery actually includes the repair of the ligament inside the knee. They would not bill a separate code for this. However, the surgeon could bill a 59 modifier if there were a separate procedure at a different site during the same visit, such as an elbow ligament repair. Let's say somebody came in after a car accident. I know there's been discussion about prepayment audits versus post-payment audits. So post-service audits are not a good method for enforcing coding compliance because it's so long after the fact. It does not protect the patient from excess out-of-pocket costs, misses the opportunity for provider education, and is unevenly applied only to the practices being audited. I think this is a key point here. We are only able at Blue Cross to audit a couple of practices each year. And the recent practice we audited found that 25% of modifier 25 codes were billed incorrectly. Now we are able to audit all providers, all practices prepayment. That's why you're hearing about this from providers. Most of them have never been audited by us before, and their incorrect billing practices have gone unchecked. It may be helpful for the committee to know some data we have to show the impact of the modifier 25 and 59 codes. Blue Cross receives over 9 million lines of claims, accounting for $1.8 billion in claims paid. Of those claim lines, about 7% have modifier 25 or 59. Of these 7%, the claims edits applied to only 5.4% of those claims submitted with those modifier 25 and 59 codes. Providers do have an opportunity to submit medical records to support their modifier billing. Overall, only 8% of the claim edits for modifiers 25 and 59 are being overturned due to medical record submissions. Once we have a year of complete data, we will gold card certain providers for the use of the 25 and 59 modifiers if the record review suggests a practice is using those codes correctly. And also, I had a separate point I wanted to make. We did remove all low volume providers, which was 20% of providers using modifier 25 and 23% of providers using modifier 59. Most of these were smaller or independent practices. In summary, Blue Cross believes that applying claim edits to modifier 25 and 59 is necessary for controlling costs. We're obligated to review and adjudicate claims appropriately. Yesterday, Representative Farlise Rubio gave a recap of testimony from House Education on Friday when Mark Page of VHI talked about why school budgets are being so adversely impacted by healthcare costs. School boards, municipalities, state employees, and your constituents are relying on us to ensure that the healthcare bill they get after a trip to the hospital reflects the services they receive. For VHI, like all our members, 55% of the cost is due to rising hospital budgets, and 20% of the cost is due to rising pharmaceuticals. The Green Mountain Care Board should be applauded rather than gutted for finally taking real steps toward controlling costs. This is the first year the Green Mountain Care Board has made significant cuts to hospital budgets. Please don't give in to their pressure to change the Green Mountain Care Board, just as they are finally making progress toward real cost containment. Vermonters are drowning in healthcare costs they cannot afford, and they cannot continue to pay for services that were not provided. Thank you for your time today. I'd be happy to answer any of your questions.
Thank you very much. And I'm hoping that you at some point can submit that to Claire so we can have the testimony put on our
Yes.
page and have it access to it. Great. Alyssa, and then Melanie.
I got a lot of questions. So first of all, thanks for coming in. So something you just said about VHI, the increase in rates is mainly due to hospitals and pharmaceuticals. So why would Blue Cross Blue Shield implement a policy that really only is specific and targeted specifically to physician charges, which are not the driver of increased costs?
Hospital costs are a driver of 55% of the budget, including physicians' costs and providers there.
Okay, so you're not just referring to inpatient,
Right,
like hospital, you're
Hospital
referring
budgets.
to inpatient physician as well.
right.
Okay. So you were talking about how you've removed these edits for low volume providers,
Right.
smaller providers. Are those providers because they are either independent or what is their specialty? And to that point, what specialties have you identified with your claims edits and your denials, or pre-adjudication audits? What specialties have you identified as being most impacted? And are the provider types, because you gave like an overall of this number of claims, this percent has a 25 modifier, this percent has a 59 on it. But we do know that there's only certain provider types that consistently would use these particular modifiers. Have you identified which specialties are being most impacted by this?
Sure. So I can say that 5% of the providers account for 45% of the modifier 25 and 59 claims. I know that chiropractors are very high utilizers of that. And I could certainly go back and get a list of more impacted specialties.
Yeah, I really would like to know, because we have a bit of a crisis in primary care, and I'd like to know, is primary care on that list? So now you're doing pre-adjudication reviews. Previously, you used to do post-adjudication audits. And I understand that, you could only do a few practices a year, maybe. So what sort of data was coming out of those post-adjudication audits? And how is it differing from what you're finding by auditing all claims, or almost all
And
claims?
can I just ask a clarifying question to this?
Yeah.
So you said you post-audited and now you're pre-auditing. But your pre-audit is basically denying all the modifiers and then determining what to do according to the testimony we heard this morning.
So let me come back to my numbers. We are denying 5.4% of the 25 and 59 modifiers that are billed.
Okay, so that's discrepancy between what we heard this morning. So we're gonna have to drill into that at some point with Blue Cross Blue Shield and get some numbers on that. So go ahead.
But it may be that some providers are adversely impacted if they're not billing correctly. Or
But a pre-adjudication audit is the computer saying, we're not sure if you billed correctly, we're going to check you out. So that wouldn't be the case.
so let me start with the first part of your question, which was when we were doing post-payment audits, one of the issues is we have to claw back money from providers, and nobody likes that. And that impacts, as Sebastian knows, that impacts, what members have paid out of pocket. Somebody with a high deductible plan might have paid for that entire visit already. But in a recent primary care practice that is well known to many of you, audit, 25% of modifier 25 codes were billed incorrectly. And I just said, we're only denying 5%, not 25%. And I can provide a citation for this, but also in a recent Health and Human Services medical record study, they found that 35% of 25 modifiers are being billed incorrectly. Again, we're only denying 5.4%.
So that article you cited, is that a national article or Vermont statistics?
That's national.
Okay.
And the Vermont statistic was the practice that we audited, a Vermont practice.
Okay, so I want to make sure we have, I'm sorry.
No,
I just want to make sure we have common language. So I'm going to describe what we heard this morning, and I want you to provide where your 5% is coming in. So what we heard this morning is that if a provider is using a modifier 25 or a modifier 59, it is going through, and I forget the system name, but it is going through a computerized system, and it is being denied unless there's a couple practices or a couple scenarios where that's been worked out and you're giving them a pass. It's being denied, and then it goes through a process where if they have the wherewithal to appeal it, and then they're waiting for Blue Cross Blue Shield to come back and say whether it's continued denial or you're going to pay it. So where does your 5% figure fall into that?
Sure. 7% of all claims have the modifier 25 or 59. Of that 7%, 5.4% are denied.
So it's still a very large percentage of the 25 and 59.
It's 5.4% of the 25 and 59, sorry.
Can I clarify that real quick?
Yes.
So when you say denied, are you saying denied by the software, the claim check software, or are you saying denied finally at the end of all this review of submitting notes? Are you saying that they denied 5%? What percent of 25 modifiers that are submitted on a claim are coming back on the original RA that just says, remittance advice, that just says, we're not paying it? What percent of the 25 modifiers are coming back as the original rejections?
Sure. The original rejections are 5.4%.
Okay. So
I think that's what we heard from providers at all today.
So I think there's also nurses that review these, and I can provide more information on that. I don't have the details.
Okay, so what we want to see is what is, of all claims submitted to Blue Cross Blue Shield, what percentage has 25 and what percentage has 59? And then of those, what percentage is being denied by the computer system? And then of those, what is being reviewed and approved or denied?
Okay.
If we can have those three
Yeah.
sections, that would be great.
And of those denied, only 8% are overturned.
What does that mean by over?
That means the provider submits medical records to say, we think this should actually be paid. So of all those denials, only 8% are overturned, saying they showed medical records that.
Okay, and so again,
I think giving those numbers, we'll
yeah,
get,
if we can put everything in writing, and then I think
Yeah.
that's another area we'll need to drill down into, because the testimony we heard this morning is that a lot of people are not appealing because the process has been completely cumbersome. So, all right, I'm gonna let you get back on, and then we'll still go to you, and then we have Art.
Who's doing the reviewing? Who's looking at the submitted documentation against the claim and making the determination whether or not that was appropriately billed or not appropriately billed?
so if a provider gets something denied and they want to submit information, nurses are reviewing that information.
Are those certified coding experts? Or are they nurses?
I will have to get you that specific information, but I believe they're certified coders and nurses, but I will get you that information.
So we heard from UVM Health Network this morning that they are not even submitting documentation unless their certified coders have reviewed the documentation and made the determination these modifiers are billed correctly. And you're saying only 5% your nurses are overturning that versus a UVM Health Network certified coder making the determination? So who's right and who's wrong, I guess is my question.
So yeah, I think it might be helpful if we actually just get you those numbers.
That would be great.
That would be great.
Okay, thank you.
So you talked about how, at the beginning of your testimony, how there are lots of claim edits. Every insurance uses claim edits, Medicare, Medicaid. There's standard industry-wide edits. You have put into place in 2023, January, new claims edits, but you were talking about Medicare. Does Medicare currently utilize all the claims edits that Blue Cross Blue Shield of Vermont is currently utilizing? Do your claim edits match exactly what Medicare or CMS has determined are the claim edits that should be used?
Medicare and CMS do 25 and 59 month edits. We haven't done a crosswalk with our plan to CMS.
Does Medicare reject every claim that has a 25 modifier on it, asking for documentation?
I don't work at Medicare, I'm not really sure. But I doubt that they deny everyone, and we deny 5.4%.
And my last question is, I promise. My last question is, you indicated that previously you used to do post-adjudication audits of practices, but that you only had the resources at Blue Cross Blue Shield to do a couple practices a year. So I'm wondering how previously you could do a randomized couple practices per year, but now you have the resources to be able to review every single 59 and 25 modifier, which must be hundreds of thousands of claims. How do you have the resources currently to do that when previously you could only look at a couple practices every year with maybe a full disclosure? I've been through a Blue Cross Blue Shield post-adjudication audit before. I think they requested maybe 50 records over the course of a year and analyzed those 50 to get a percent. So I'm wondering how you're able to do this high volume when previously you couldn't do more than a few hundred claims a year.
Sure, I mean, some of it is technology and some of it is getting, extra help with the staffing through vendors.
Melanie?
I have just two questions, and forgive me if I'm not completely fluent in the language
Sure.
of this, and I appreciate your testimony and time. I think I've heard you say that there are 8% of the modifier claims were denied. Is that correct? What the number you used?
7% of the claims have those modifiers, and we denied 5.5%.
So I'm curious how many are still being like held up that we don't know the results of? Like, are there some, it sounds like there may be a backlog of like getting these claims through. So I'd be curious of how many are just in limbo right now. So no one's getting paid and we don't know the status of them. So I would love that data if we could see that.
Sure, we can get you that data. And to clarify, we take up to 60 days once somebody submits medical records to get back to them. We average about 30 days to see whether we're going to overturn that or not.
That actually brings me to my second question is that I heard you testify saying so the reason for this type of auditing system or adjudication is to have it be uniform, streamlined, and accurate. I'm curious because when we were hearing from the testimony earlier today, 60 to 90 days for things to come back, I'm wondering what metrics are you using to measure whether you're meeting your goals of these 3 indicators? Because it sounds like there's a disconnect from the testimony you've heard this morning to what your goals are. So with any new system, there needs to be assessment and then revision and responsiveness. So I'm curious what metrics you have in place to do that. Measure that.
Sure. So we're looking at, metrics each month as they come in. And what we're going to do is after we have the 1 year of data from this, and there's always a claims run out. So January 1st is not the 1 year that we'll look at that. We'll definitely remove providers who have submitted records and shown that, that they are accurately coding things, or remove providers who, did not have edits. I can give you the percentage of those, but that might be easier. Like we have statistics of how we will remove providers or gold card providers, and it would be easier for me to put those in a document.
Art?
Yes, this is kind of philosophical, I guess, but when a provider enters in these codes and they're incorrect, or the modified 25 modifiers say, does the office just get back a thing that says this is incorrect? Is that what they get?
I would have, I'm not on the front lines of that, so I would have to see exactly what form they get. I believe that they get a notification that that's been denied.
Okay, so they get a denial of the code. So but they don't get, it sounds like they don't get something that would say, you might want to try this code, this code, this code, this code. Maybe if you did that, the thing would work. Do they get something like that?
So we do have a provider relations team that can work with practices. For example, we've worked with a Vermont-based dermatology practice that has multiple sites, not one that you heard from earlier today. And they've been able to work with us to change their coding practices. And in fact, I had heard things like someone had complained they needed to schedule a patient for a second visit because they couldn't get things done and coded right on the first visit. And again, we've worked with practices to help them to code things correctly, that a second visit should not be necessary.
Okay, I just as somebody that's had 72 years of healthcare, it seems to me that if I got things that just said that's been denied, I go, so what do I do now? I mean, I was a football coach for a long time. If I saw a lineman with poor footwork and I said, your footwork's no good, and walked away, that wouldn't help the guy get better footwork. And so it seems to me there's a reason to, train these people so that they put in the right codes or make suggestions for codes. Just in my pea-sized brain, just saying it's been denied is not helping. And, and you got to understand, we heard all morning from people that, people are ready to quit over this stuff because it's just so frustrating. So, and there's both sides of everything, but it seems like there could be something done to make the thing fit together.
Sure, and thank you. We have done a training in partnership with the Vermont Medical Society on the modifier 25 and 59 codes specifically. And we're going to do quarterly training moving forward.
I hope providers all know this. Put the word out to the providers so they're aware training is coming. That might help.
And I'm probably not good at analogies, and I'm sure someone can pick this apart, but,
It's no good, no.
it might be akin to somebody, we might be a little closer to a referee in a football game where we throw a flag and we say, over the line, but the coach is the one who's actually going to have to give that teammate the guidance on what to do.
Thank you.
Melanie?
So this is I used to be an 8th grade middle school teacher, so all about supports and helping people learn and get it right. So would you walk me through, I'm a coder and I'm struggling with this and it's affecting my practice and I want to stay. What supports does Blue Cross, can you just walk me through what I would do? Because we've heard different things, like how does someone get through your system to be able to be successful?
Sure. I mean, there could be two answers. One would be you can contact our provider relations team. The other would be that, let's say you're an ophthalmologist, you have an ophthalmology association, the American Medical Association, and CMS, who all have guidance on coding, appropriate coding, what should get paid, what shouldn't get paid, and all these organizations have training for you as a coder.
And I heard that it was almost 2+ hours on those calls, wait time. So that was concerning to me. And are you aware of that? And if so, like what kinds of modifications are you doing to be more responsive? People are trying to see off the patients, some 2 hours wait.
It is, and I can take that back, and we can take that back to our teams.
I have a couple questions. So first, I want to say I appreciate you bringing up cost to the conversation, but I think we need, because that is one of the things we are responsible for, and we know healthcare is expensive, and we know the system of care has costs in several different areas, and one is provider burden, and we heard that loud and clear today. And I understand cost of healthcare is being driven by pharmacy and hospital, but the costs that providers are having to increase in staffing, increasing in time, changing the way they're seeing patients, that's a burden to our system as well. So I would like to understand, we've talked percentages, and this might be something you have to get back to me on, but I want to understand, I want to see the percentages, but I want to understand how many claims dollar-wise. So let's look at the dollars. So what are we denying? What is eventually on appeal being paid back? What is not? Because that is a cost to our providers. What is the cost at Blue Cross Blue Shield? And I can send this, I'll invite you as well. What is the cost to Blue Cross Blue Shield to have this system in place? And what is needed to work through the process with providers when they do appeal? I'd like to understand that total cost. I would like to understand, I actually have a whole list of questions I'm going to send to you, but what I would hopefully like to have answered now is, you say that one of the reasons, I believe you said that one of the reasons you put this in place was the cost of healthcare, but what specifically, what cost, what data did you have before January of 2023 showing that you needed to do this?
So usually when we work on projects, we look at the opportunity. And so, whether it's an internal project or a project with a vendor, we do an opportunity assessment. And so we can do something like look at all of our claims from 2020 through 2022 and see if we implemented a certain change or worked with a certain vendor, how would that make an impact? So that was the opportunity assessment that was done.
So you worked with, and what is the name of your vendor?
This one is called Cotiviti that I'm talking about today.
So you worked with Cotiviti, talking about opportunities of how you can reduce cost in healthcare, and this was the solution that was
Right.
most effective. And with all of the complaints and the meeting, the nice family meeting we talked about earlier that happened in November and December, do you still feel this was the best decision to make?
I do. It saved our members tens of millions of dollars.
And so in premium cost, so where
Right,
did
which
the premiums go down?
premiums will be higher or would be higher without this.
And can you quantify what that would be?
I will have to get the exact numbers.
Okay, so I would like to understand how premiums have been impacted. I'd like to understand your costs associated with this. We've asked providers to send their costs so that we can look at the big picture and what really truly is the effect of this decision. I'm also a little concerned of the statement, and I apologize, I don't have your testimony in front of me, but you are concerned about fraud in billing. And was there something other than the conversation with your vendor that you felt there's fraud happening in the state of Vermont?
I think there's a more general answer, which is fraud, waste, and abuse happens in healthcare in Vermont and every state. And, might be filling someone's prescription more than it needs to be filled. And we knew that our old ways of doing things, auditing a couple of practices a year, was not going to catch that. So I think that's information that led us to a different solution.
Okay. Why is Blue Cross Blue Shield the only insurance company doing this in the state of Vermont?
We are not the only insurance company editing 59 and 25 modifiers. That CMS will do this when they audit charts.
Okay, let me rephrase my question. Why is the provider network in Vermont only indicating that Blue Cross Blue Shield's process is one that is causing them distress and cost and provider burden?
I don't have a good answer for that, although I think, as I said before, most of these practices have not been audited for how they process or bill claims in the past. And so I think you're seeing some abrasion. I do have to say some facilities, some practices are impacted a lot more than others. UVM has been impacted not just because of their size, but as a proportion of their size, more so than a facility like Rutland Regional Medical Center, which I don't know that people have heard any complaints from them. We really haven't.
We've heard complaints from all hospitals.
Good. But I would like to say some facilities have been much more impacted than other facilities, some providers. Again, all of their 25, 59 modifier billings go through and others are more highly impacted.
Okay. I have one last question. Alyssa has a question, then I do want to summarize our conversation. Is this practice and this decision to change the way the modifier is done have anything to do with the relationship you now have with Blue Cross Blue Shield of Michigan?
Yeah.
I'm sorry, I know we didn't talk about it and you didn't address it, but one of the other issues, and I really felt I wanted to ask about it when you were talking about fraud, is the denial of claims for invalid diagnosis code, which diagnosis codes are not necessarily invalid, they're just not as specified as you would like them to be or wish them to be. The dermatologist this morning spoke about how she would just change an unspecified neoplasm because she doesn't know what it is, and she would just drop it off of her claim. Would you say that having an unspecified code, which is a valid code, I might add, not an invalid code, would you say that that is a sign of fraud? If a provider puts a code that's not quite as specified as Blue Cross Blue Shield would like, is that fraud?
I don't think that's fraud, but it may not be appropriate or sufficient. If you amputate a left toe, it should be a left toe, and you shouldn't be billed next week for amputating another left toe.
That's not a diagnosis.
So amputating I guess what I'm saying is amputating a toe is a diagnosis. I'm not using the right words, but if you amputate a toe today, we need to know which one. Because if you're amputating another one next week and we're getting billed for it, we want to make sure you're not amputating the same toe and charging twice for it.
That would be procedural coding, not diagnostic coding.
Right.
So
I could,
modifier for which toe did you amputate, as opposed to a diagnosis, which would be gangrene of the right toe or gangrene of the left toe. But I guess my point is that you said that you put these in place to guard against fraud, but would we say an unspecified viral infection because you haven't run every single test to figure out exactly which virus the person has? Would that be fraud? Or would that just be sometimes you don't know what something is?
what I'd like to do is get back to you with an answer about unspecified diagnoses.
Okay. That would be great.
More helpful.
Great. So we really appreciate you coming in and your testimony, and this conversation will continue. I will say, I think I can speak for the whole committee. We have great concern about the disconnect of what we're hearing from providers and what we're hearing from Blue Cross Blue Shield. And we are in a moment in healthcare where our providers can't take on any more burden. And we need to be looking at the cost throughout the system. And some of that cost is happening right now with provider burden. So we want to look at the whole picture. So, what data does Blue Cross Blue Shield have that makes this a valid process versus what is the total cost to the system for this process? And is it really just not appropriate for the state of Vermont? So we'll send you a list of questions. We're going to hear from DFR next. We have a bill coming out. And so our next step after Sebastian, once the bill is introduced, is we'll walk through the language and we'll have everyone come back in. And I would hope before that time, we'll give you plenty of time before that time to get the answers to these questions. So we need to figure this out. But thank you very much.
Thank you.
Thank you. Sebastian.
Good afternoon, everybody.
Afternoon.
Madam Chair,
Oh, yes, I'm sorry, Topper.
yeah, before Sebastian starts, thank you. When you submit those questions, we use the term, we'll give you enough time to get back to us.
Oh, I will put a deadline on it.
Okay, good, thank you.
Yes. Don't worry about that. Are you good, Topper? All right, it's all you, Sebastian.
All right. Sebastian Arduengo, Assistant General Counsel at the Department of Financial Regulation. And here this afternoon to not only bask in the sunshine pouring through the window, but to explain to you all the department's role in all of this and what the legal background is. So I haven't prepared written testimony today, but I did submit some documents to Claire that I'll be referencing throughout my testimony, so you'll be able to access those on the legislative website. So the first thing that I want to talk about is the underlying statute that puts DFR in the middle of this, and that's 18 VSA 9418A, little a. And what that statute says is that health plans cannot implement non-standard claims edits. So whatever they do to edit claims has to be consistent with the current version of the CPT, this, or one of the other commonly used coding conventions. So there are HCPCS codes, the Healthcare Common Procedure Coding System, the National Correct Coding Initiative, and others. And what the statute requires is that when editing claims, payers have to adhere to the standards that are in the code books. So with that in mind, I wanted to work you through the department's analysis of the code edits that Blue Cross has implemented here. So if you want to follow along in your code books, Appendix A. Yes. If it's, I know that yours is a little bit old, so if it's not in Appendix A, you might have to use the table of contents.
You just made her weak. It first.
All right. Okay, so modifiers 25 and 59, as you've heard, and I'm really grateful to Dr. Lin and Dr. Weigel for explaining all of that to you. That way I didn't have to resort to the whiteboard.
We love the whiteboard. We were hoping for the whiteboard. Really authorized it for us, which was great, yes.
So both of these modifiers more or less do the same thing, except that modifier 25 is used for evaluation and management codes, and modifier 59 is used for other CPT codes. So for the simplicity of discussion, I'm only going to focus on modifier 25 here. So what the descriptor for modifier 25 says is, in part, quote, a significant separately identifiable E&M service is defined or substantiated by documentation that satisfies the relevant criteria for the respective E&M service to be reported, which means that if a provider is billing this code, the code descriptor itself says to submit documentation indicating that it was indeed a separately identifiable service. And the example that Dr. Weigel used was really good, so I want to come back to it. And he used a chiropractic example, but there's the example I want to use is very similar, but it's in the context of occupational therapy service. So if an OT saw a patient and performed a service, let's say it's an established patient coming in with a treatment plan, and they billed for that service, but then they also billed the code for a reevaluation for an established plan of care, which is CPT 97168. They could not then bill modifier 59 for that reevaluation because the reevaluation is a subset of the service they were already providing according to the plan of care. That code is meant to be a standalone code. So even if the provider in that instance submitted documentation about the claim, it would still be denied because it's an inappropriate use of modifier 59.
Okay.
So with that in mind, the department determined that the claims edits that Blue Cross was implementing here were standard. The only thing that had changed, what makes Blue Cross different from other payers, is that they've moved from performing these claims edits after the fact to performing them before payment. And I think that there was no disagreement among any of the stakeholders that given the magnitude of this change, because of how commonly modifiers 25 and 59 are billed, that the communication and the documentation that went out before this change went into effect was not sufficient. And you heard about the training that Blue Cross Blue Shield put on with the medical society. Things like that should have happened before this edit was implemented. And in the meeting that the department facilitated, this is the November meeting that people have talked about, although it happened in September, so. I just want the record to reflect that that meeting was on September 27th.
Okay, we'll note that.
Yeah. A lot of what we heard from providers and that Blue Cross was able to identify and immediately fix were really silly things like the email address to report issues or submit requests for redeterminations was wrong. And it was not listed, it wasn't in the documentation. And this is also something that actually the department and Blue Cross need to be better at making sure are in place before these claims edits go into effect, to make sure that the documentation is there, that providers know what they're supposed to do when these claims get denied. And so even if a claims edit is standard and comports with the language that's in the manual, it is not absolutely disruptive to our providers. And going back to the statute, I think that the legislature has recognized this. And that's why in subsection K of the statute, there's a requirement that Blue Cross Blue Shield of Vermont, at least annually, meet with the medical society to discuss issues related to claims edits. This has not happened. We kind of got off track during COVID, but we're going to get right back on track, because when we don't have these conversations, then issues like this happen, which a lot of these issues were just entirely preventable and could have been addressed by like doing the training before the fact, making sure that the provider coalition, not just the medical society, was clued in to how potentially disruptive these claims edits would be. And you know, we know that providers get a lot of material to read, and not every provider can hire an MBA to look through all of these different policies. So the more that the provider community knows what's coming down the pipe, the more that we can all prepare and have systems and procedures in place when these edits go live. And I just wanted to echo Dr. Weigel's testimony, just stressing that, yes, the health plans absolutely have a duty to their members to ensure that claims are paid appropriately. And we view claims edits as a necessary part of that process. We just don't think it should be a seismic event that takes place all of a sudden.
Thank you for that. I agree. Did you have any more?
I'm going to stop there for questions.
Okay. Melissa?
Is there anything in statute that requires an insurer, when they pay a claim, to communicate a denial or edit reason with specificity? Because we heard a lot of testimony this morning of basically people being like, what happened and why? Is there
Yes.
anything in statute that requires they do that?
So just to back up and explain what the department has heard from providers with respect to the reason for denials is that providers would receive more or less a generic denial that clearly states why claims were being denied or what they could do about it. And providers could call into their provider relations rep to get that information. But that is a process that needs to be improved because under Chapter 221, you are absolutely correct that payers are supposed to provide a reason for the denial, and getting a denial that is generic is as frustrating as if you've ever had a computer error and it says error, unknown error. It's just like that.
Can't fix it. You don't always.
And with respect to these claims edits, specifically, it's the department's understanding that Blue Cross has worked with the Health Network and other providers and with their vendor Cotiviti to basically develop a spreadsheet for providers that list all of the claims that were caught in the edit and letting providers know about that so that providers can then go and seek redetermination. And a quick note on terminology. I'm using the term redetermination. You might have heard providers use the word appeal. We're talking about the same thing, but the reason I'm not using the word appeal is that legally speaking, an appeal is an appeal for like a denial of a claim for a medical reason that can then be externally reviewed by the department.
Oh, okay. That's different. Okay.
Yes.
Amy.
Yes, I see you. Yes.
My wheels are spinning because I'm thinking, okay, so the claims, the edits for the modifiers, those are not denials, even though in provider terms we tend to use denial. Those are just stopping of the claim saying you need something.
Right.
However, claims are also being denied for, and this is a true denial, this is not a requesting additional information. Claims are being denied for, I can give you the code ME63, but it's invalid primary diagnosis. But that is actually not an accurate denial because it is not necessarily the primary diagnosis. And I do not believe on the spreadsheets that are being, I do not believe these are being captured on the spreadsheets.
Yes.
And so therefore, Blue Cross is denying a claim without an adequate denial, a specific denial reason. And I believe in statute, it says that they must, when they deny a claim, give a specific reason and also recourse basically the information to allow for recourse on that denial. So I think we're talking about two different things here.
Yes, so when I was talking about the redeterminations, I was talking about the issues related to modifiers 25 and 59. The denials for invalid ICD-10 claim is a different error, unknown error, and we have been in communication with Lou McLaren at Blue Cross about it, and I think you've been a part of those discussions, Representative Black, and a few other people from the provider coalition. And yes, we agree that a denial for invalid ICD-10 is completely insufficient. And when we had our meeting, we did discuss how some providers were almost taking the spaghetti on the wall approach to coding. Like, well, maybe like this diagnosis will work. And some were even reporting that they would submit the same claim with the same diagnosis for two different patients, and one of them would pay and the other would be denied. And there seemed to be no rhyme or reason to that. So my understanding is it's something that's still working towards a resolution. But I will say that under 9418, and this is not really a comfort to providers, but I want to mention it. For claims that take over 30 days to process, payers must pay interest on those claims. Yeah.
Brian, and then Melanie, and then Leslie.
Thanks.
Brian, are you there?
I was ready, and then I didn't want to interrupt, and
No, I appreciate that.
Got up, you called on me. So I wanted to ask if anyone ever audits the payers to see, like, because we just heard an example from you about how they're supposed to pay interest if they take longer than a certain amount of time. I don't want to make any accusations of anyone, but I'm going to go back and look and see if I was ever paid interest. I'm wondering, like, how many times, if anyone ever audits for falsely denied claims, or mistakes made by the computer systems that they use, or mistakes made by the person you call that's like not, like in another country at a call center, after waiting on hold 90 minutes to talk to them, who tells you that you made a mistake, but then they made a mistake. I'm just curious, like, if there's any auditing of that happens and if that information is available.
Yeah, so that's the kind of thing that the department does in the context of an examination. And we just finished a pretty big examination of all of the payers with respect to contraceptive services that resulted in a multi-million-dollar restitution payout. But when the department does those exams, they tend to be quite targeted and limited by our resources. We have a team of 5 market conduct people who do enforcement for every line of insurance. And I could keep them busy more or less indefinitely just working on health insurance related issues.
Thank you. Everyone's understaffed. Melanie?
I just want to say I appreciate so much your transparency and like the after review that you're providing for us and giving us a picture. It's really helpful, and that's how we'll improve in the future. One of the things that I was curious about, you just touched on it, so I just wanted, like, it was around the window for what is a reasonable amount of time to have an audit happen or having information come back, and I'm wondering if you could explain what those guidelines are. And then my second question about that is, were those set, because it sounds like Blue Cross and Blue Shield is the only company that's withholding payment and doing it before, like doing the audit before, and if those timelines were set for the other model, I think we need to examine, is it still fair to ask businesses and providers to wait a certain amount of time? I know as a small business owner, I couldn't wait 90 days to get paid. So I'm just curious, what are the guidelines? How are they set? And do we need to maybe look at that with this, with Blue Cross and Blue Shield as a withholding payment?
Yeah, so the guideline that's in statute for prompt payment of a claim is 30 days after receipt of the claim, after which the payer has to pay the provider interest. So the statute does recognize that there are cases, and especially in the world of health insurance, where there's a long claims run-out period and claims might be subject to prior auth, and there are just a lot of reasons that it might take longer than 30 days to process a claim, that payers can do that, but there's a statutory remedy for the provider.
And do providers know that? Is that part of the training?
I can't speak to what providers know or don't know about the law, but I know that the provider advocates are well aware of that.
Leslie? So I wish I had your whiteboard.
Oh, it's right there. Do you want it?
Not kidding. I'm just trying to understand the system and trying to figure out who's in charge. And I'm not getting the feeling, like I haven't seen the statute since you just gave it to us. I haven't read it. But I'm trying to understand, like the AMA writes these books.
Yep.
Right? But after that, they're done. So they have no other involvement, right?
Yes.
So they just write the books. So then they go to the insurance companies, these books, and they go to the providers who then have to intersect and agree on payment.
Yes.
And then who's watching the whole system? Is it complaint driven to you? Or is there any kind of understanding of how this works as a whole?
Yeah, I think that Dr. Lynn's testimony really spoke to this, in that payer fragmentation is a tremendous problem in healthcare, in that every payer, be it all of the private payers and all of the public payers, have their own payment policies, require claims to be submitted different ways, have different prior auth requirements, and even to the point of who is in charge, who regulates all of these different systems, really depends on what payer you're talking about. Self-funded payers are generally regulated by the federal government. Medicaid is a federal state partnership. There's original Medicare, Medicare Advantage, all of those are subject to different regulations. So the short answer to your question is no one is really in charge of the entire system. There are entities that are, like the department, that are responsible for the oversight of parts of the system.
So is there an opportunity for us to look at this at statute and try and get some cohesion anywhere, or is it just?
Yes, there is. There's a bill coming up.
Okay, so that's what you're thinking about in your bill?
Yes.
Thank you. I appreciate that, because I tell you, my head's whirling, because what you just said really sounds very broken. And it's just another example of our broken system, which wouldn't have come up, I don't think, well, you know about it. I just learning about today, so.
I think that is one of the few areas where all of the stakeholders could again agree that the way the healthcare system works is not ideal.
Yeah.
Alyssa. Last question, almost to Leslie's point. You know, you spoke about that that Blue Cross Blue Shield is within their rights. They're not doing anything in violation as far as they can put these edits in place because they meet sort of the standardized edit things. I mean, they've chosen to take them a little bit.
Yes, it's consistent with the language of the CPT.
Yeah. So we're looking at that and we can say that they are doing that, but does the state have to, or DFR have any role as sort of an arbitrator between, because we heard UVM Medical Center, their certified coders are saying these are coded correctly, and nurses at the entity that Blue Cross Blue Shield has outsourced this to is saying no, and there's no recourse. Has DFR looked and said, can we see them and see if we think they meet the requirements? Have we delved into that a little bit?
So like I said, there are cases where like we have done examinations of claims, but in general, we don't act as the arbiter of who is right in coding, just as like a matter of regular course, because it's something that is really outside of our institutional expertise. I have a whiteboard, I have the books, but I'm not a certified coder. None of our market conduct examiners are certified coders. We really rely on direct input from the provider community to do what we do. So
So a payer, essentially what we're saying is that a payer can say,
Payer has
we're
the
not
last
gonna,
word.
they've got the last word, and their only reason needs to be because we said so? I mean, and the state has no recourse on that.
the state has no recourse in terms of determining like who's right with the coding, just because we really can't say. But we do have a lot of authority when it comes to like determining whether or not a given claims edit is consistent with the guidance. And we have authority over how these claims edits are implemented.
Daisy and then Art.
Do you follow MacPac and some of their briefs and recommendations, white papers and whatnot?
Can you say what MacPac is?
Medicaid and CHIP payment access commission?
I'm familiar with MacPac, but I haven't followed any of their recommendations.
Okay, never mind.
Okay.
Art?
Yeah, I keep hearing that you got this on one side and this on the other, and I can't help but thinking, why can't both sides come together to figure out at least of the major codes that are at issue, the major procedures that are causing a lot of the problems, and come up with the proper codes so that everything gets straightened out? I guess I know that sounds simplistic, but I don't, it seems like training would help. It seems like the provider, I get payer and provider mixed up, but provider met with the payer and figured out these codes and what would work, what code should I use in this case, that a lot of the problem would be avoided. Is that too simplistic, or is that not maybe a solution to this?
We agree that provider training is an essential component of this, and not just providers, but there are great providers like Dr. Lin and a provider that helped us out during the contraceptive examination was Dr. Lauren McAfee at UVM that do their own coding. And it's so great to have individuals who know like how the clinical world translates to the world of billing codes. But we also need to include billers and coders in that conversation too. And to your point, yes, the more training there is on what is appropriate to code in which situations, which I acknowledge is a bear. And the more access that providers have to payers if they have questions, those are all good things that we need to do better at working towards.
Can you identify, could you not identify the top 20 things that get miscoded and at least start there? I mean, is there something like that could kickstart the process? You know, there's got to be something that not every provider, but most providers are continuing to do wrong. Just a thought.
Right, and I think that's why the statute requires the Medical Society and Blue Cross to have these annual meetings, and I've already spoken to Jessa Barnard and to Sarah Tichat about getting them started, and not just on an annual basis, but probably at least on a biannual basis to talk about like what are the providers saying, what is the payer community thinking about in terms of claims edits or other initiatives to ensure the correct billing and coding.
And Art, if I can just add, I think there is I don't want to say the word assumption, but that's all I can come up with, that they're coding wrong. And I'm not sure that's an accurate assumption.
Say that again.
I think there's an assumption on your question and from others in the room that providers are coding incorrectly. And I'm not sure that's an accurate assumption to the level of what we're dealing with.
Right, and right.
So,
you're absolutely correct, but with the other side there, you could hammer that out.
Yes, absolutely. And yes, and what Sebastian is talking about is in the bill that's coming out that will be reinstituted.
All right.
Did you have any more testimony?
No, that's it for me. Thank you.
You're fine. Thank you very much for coming in. I appreciate it. I just have a couple of thoughts I want to put out there as we think about our next steps and for everyone that's going to be submitting more information to us. So while this is standard, right, editing process, while others do it, while the claims edit itself is being appropriately used, I'm finding in the testimony I've heard that I'm not sure we're solving a problem by what's happening. Blue Cross Blue Shield is the only payer doing it. The decision was based after a conversation with a computer vendor that does, claims edits as an opportunity. And while there is concern about providers coding incorrectly, and absolutely we have to consider the cost of healthcare to Blue Cross members and everyone else that buys commercial health insurance. There is a cost to what is happening, a big cost. And a lot of it is going to be a cost that we can't get our hands around, but I want us to remember that. So we've heard, I think, from all sides at this point, and so we'll send out a list of questions, get some answers back. The bill will be introduced. We'll walk through the bill as the next step. and then we'll come back to this conversation. But I am going to say again to anyone listening and anyone involved in this, if there is data that you want us to look at through this process, you need to get it to us. Yes.
I just want to say, like, I've tried to listen really carefully because I know that there are so many more experts in the room on this topic than I am. And I'm just absolutely struck by the lack of, like, I do not hear any practice improvement strategy in this. And I would expect that if, given the scale of patients involved, the scale of impact on their livelihoods, on our economy, on the healthcare system, on Blue Shield's bottom line, that there is, I didn't hear articulated, and I apologize if I didn't just pose the question directly, so maybe this isn't our follow-up. You know, what is the strategy for practice improvement? It sounds like there's money in the budget to do that. I heard there was training. But Sebastian also kind of indicated that, you know, it should have happened earlier. But is there, you know, if there's an area for improvement or opportunity, however you want to frame it, for cost savings, it sounds like that's identified by a computer, but then there's also a national trend that was identified in 25% of these billings being wrong. I just, you know, I feel like that needs to be first addressed through practice improvement rather than basically putting a logjam in patients getting access to care.
Yeah. I agree. And I would also like to say, sorry, Melanie, that, you know, so many people come to us with statistics nationally, and yes, sometimes the state plays into those same statistics, but often we don't. Like our healthcare system, we are heavily regulated. We are small. So, you know, I also question when someone says we have this, you know, this is the statistic nationally. And so and this isn't just this case, but other cases. So our decisions being made at the state level based on those national statistics, when we really need to look at our state level data. So, but yeah, so I will write that down about practice improvements. Sorry.
Yeah.
Go ahead.
No, and that's what I wanted to know about the metrics for like them measuring, comparison with measuring success, or are there places where their efficacy is, or where are there places for change, so they can inform their practice. And so I would look forward to seeing that, because something this grand and big and affecting so many people, you can't just hope that they got it right.
Right. And hasn't been resolved in a year's time. Leslie?
So as I said earlier, this is kind of the first time I'm having a chance to think about this. So was hoping I could read the statute and maybe look at some of the testimony. And I think you're going to send yours again, which would be great. So I was just wondering if you're willing to share the questions that maybe we could think about contributing to this.
Yes, absolutely. Yes. I will draft up the list of questions. I will send everyone for feedback, and then we'll send them to Blue Cross Blue Shield. And if there's questions that we want to send to the provider network, we can do that as well, without a doubt. And if you reach out to Jen, she can send you the statute.
He linked it.
Okay.
He's the best ever.
Okay, great. And Alyssa needs to stop giving me her questions, otherwise we're never going to get anywhere. Mari?
I just want to say, even though I'm not feeling well and I would have loved to have chimed in, I thought I'm really proud of our committee right now. I think those that asked questions were really smart questions and well delivered, and just great job today.
Thank you, Mari. Okay, let's talk about tomorrow. Tomorrow we are 8:30, don't forget, in room 270, the pavilion for Bi-State Primary Care Association, and then we'll go right into Act 167, and we are joint with Senate Health and Welfare.
For both?
For both, yes.
So we'll be there all morning.
We'll be there all morning.
What's that?
Yes. 167 is, it was passed in 2022, so before you were here, but it directed it did many things, but one of the things it did was directed Green Mountain Care Board to look at hospital sustainability and specifically hire a consultant, and then also do community conversations And so they've been doing that work. There's a lot more work to do, but they're going to give us an update on that. And then we potentially are also getting an update, not quite sure about this, on the AHEAD model, which is the new all-payer model that we're deciding whether or not we apply for.
We heard about that down in Rutland.
Yes,
Yep.
yeah.
There's money, potentially money for it in the BAA. They want $1 million for a consultant.
Oh, okay, the AHEAD.
You mentioned,
Okay, that's good to know.
oh, the healthcare reform.
Yeah.
Pat Jones.
On that AHEAD, Pat Jones. Okay, so we can be done. Thank you for today, and the floor is at 3:00.